Hi, my name is Navdeep. I'm going to start my presentation on alcohol withdrawal syndrome. So I'm going to start with introduction. Alcohol withdrawal syndrome is caused by sudden cessation or sudden reduction of alcohol intake in people who are chronic and excessive user of alcohol. The clinic presentation of alcohol withdrawal can vary from mild to serious, and it can lead to death in some cases. Providing the care for the patient is very challenging, and it requires clinician basic understanding of pathophysiology of the syndrome and have the ability to make decisions about medication administration and have flexibility to change the approach to the patient care. And for pathophysiology, chronic excessive use of alcohol disrupts the balance of activity of neurotransmitters, especially GABA and glutamate. GABA is a primary inhibitory neurotransmitter in central nervous system. Acutely, alcohol increases the activity and transmission of GABA and enhances an inhibitory effect and decreases the central nervous system activity, decreased coordination, drowsiness. On the other hand, chronic alcohol use decreases the sensitivity of GABA to GABA receptor. Glutamate is excitatory neurotransmitter in central nervous system. Acute alcohol intake inhibits the activity of glutamate receptors, and chronic alcohol consumption increases the number of glutamate receptors. In general state of arousal, central nervous system is determined by equilibrium of activity between GABA and glutamate. Chronic alcohol uses creates an abnormal imbalance between inhibitory and excitatory central nervous system activity. When someone abruptly stops drinking or reduces consumption of alcohol, there are two important effects. The inhibitory effect of alcohol on GABA receptor is removed, and there is increased activity of upregulated glutamate receptors. This results in hyperexcitability state that causes the sign and symptom of alcohol withdrawal syndrome, such as agitation, elevated blood pressure, and heart rate and seizure. The symptom of alcohol withdrawal syndrome depends on the amount of alcohol intake and the duration of patient drinking habit. Minor alcohol withdrawal syndrome are due to central nervous system hyperactivity. That could be insomnia, GI upset, headache, tremulence, mild anxiety, diaphoresis, palpitation, anorexia. Patient may start experiencing these symptoms within 6 hours after the last drink, and if withdrawal doesn't progress, these symptoms resolve within 24 to 48 hours. Patient with alcoholic hallucinations start developing hallucination within 12 to 24 hours of the last drink and may resolve within 24 to 48 hours. Patient experience visual, auditory, and tactile hallucination, and usually they are aware while they are hallucinating. Withdrawal associated with seizures are generally generalized tonic-clonic seizure that usually occur within 12 to 48 hours after the last drink. The seizure occur predominantly in patients with a longer history of chronic alcoholism. Other causes should be considered if seizure is focal, lasts greater than 48 hours after the last drink, or patient have history of fever and trauma. Approximately 5% of patients who undergo withdrawal from alcohol suffer from delirium tremens. Uh, Usually, delirium tremens is defined as hallucination, disorientation, tachycardia, hypertension, hypothermia, agitation, fever, and diaphoresis after acute reduction or cessation of alcohol. And delirium tremens begin between 48 to 96 hours after the last drink and last about 1 to 5 days. Delirium tremens is most severe type of alcohol withdrawal syndrome, and patient may need medical attention. Risk factor for developing alcohol syndrome are like patient current medical illness, heavy alcohol use, history of with seizure, older age, abnormal liver function, or if they have more severe withdrawal symptom on presentation. For diagnosis of alcohol withdrawal symptom is usually diagnosis with the patient history and physical exam. For physical exam, we can use like tremors in a hand, high blood pressure, fever, rapid breathing. To detect the severity of alcohol withdrawal symptom, doctor uses clinical institute withdrawal assessment for alcohol scale. This scale has usually 10 questionnaire to measure the symptom like nausea, vomiting, tremors, sweating, and anxiety, agitation, tactile, auditory, and visual disturbances, headache, and confusion. So treatment depends upon a severity of a symptoms. So like for mild alcohol withdrawal symptom, we just need a supportive care and quiet environment. Generally, like there's no pharmacotherapy needed unless there's any presentation of a risk factor. Uh, if there's a presentation of risk factor, we can use a loading dose of diazepam 20 milligram, and we need to monitor a patient for 36 hours. For moderate aware alcohol withdrawal syndrome, we need to monitor a patient for 36 to 48 hours, and we can start a symptom trigger treatment with benzodiazepine, and we continuously use questionnaire to score symptoms of patient. For severe alcohol withdrawal symptom, we usually follow a loading dose regimen with benzodiazepine, and usually we use like a diazepam IV. For treatment, like all patient needs supportive care, quiet environment. Uh, if there's any abnormality in a fluid level, electrolyte level, or nutrition, it should be corrected. IV fluid may be necessary in patient with severe withdrawal because of excessive fluid loss through hypothermia, sweating, and vomiting. IV fluid should only be reserved for patient with severe withdrawal syndrome. If IV fluid is administered, thiamine should be administered before glucose to prevent a precipitation of Wernicke encephalopathy. Benzodiazepine is the first drug of choice to use in alcohol withdrawal syndrome. Benzodiazepine usually exert their effect by binding to allosteric site on a GABA receptor, and usually they don't have any agonist activity by itself. Usually they increases the effect of GABA on GABA receptor. And benzodiazepine, most of the time we use diazepam, chlordiazepoxide, and lorazepam. Diazepam and chlordiazepoxide are preferred because they are long acting, and lorazepam is preferred in a patient who has any hepatic dysfunction. And for the treatment, we follow two regimen. If we're gonna follow loading dose regimen, we give high doses of long-acting benzodiazepine to quickly achieve initial sedation. We give diazepam 10 to 20 milligram, and we repeat dose every 1 to 2 hours until patient reaches adequate sedation. So the benefit of this approach is like we don't need to do intense monitoring and medication administration at the early period of withdrawal. For the loading dose regimen, we need to monitor our patients, especially who are elderly or who have hepatic dysfunction, because there is a risk of increased sedation and respiratory depression. For symptom trigger treatment, for this regimen, patients should be symptomatic and there should be regular assessment of patient withdrawal symptoms using CIWAR scale. It requires a close monitoring, and it should not be used in a non-verbal patient. If patient CIWA score is equal to or greater than 8, give 5 to 10 milligram of diazepam and repeat every 1 hour until CIWA score is less than 8. So once patient is stable, we need to reassess a patient every 4 to 8 hours for additional therapy. The advantage of this symptom triggered therapy, like we need to use a low doses of benzodiazepine, there's a less sedation and less risk of respiratory depression. We can also use antipsychotic agent like haloperidol to use the treat agitation, hallucination, but they lower the seizure threshold. Haloperidol should be used cautionally in alcohol withdrawal syndrome, particularly in early stages. An anticonvulsant, carbamazepine, is used extensively in Europe. It's less used in the United States because there's a lack of sufficient evidence that it prevents seizure and delirium. An alpha-2 agonist agent, dexmedetomidine, is more potent alpha-2 agonist than clonidine, and it decreases sympathetic override and release of norepinephrine. Alpha-2 agonists usually don't have any GABAergic activity to prevent and to treat delirium tremens. They can only be used as an adjunct therapy to reduce the autonomic activity that cannot be controlled by benzodiazepine. Anesthetic agents like propofol enhance the inhibitory effect of GABA receptor and decreases excitatory circuit of NMDA transmitter system. It has a rapid onset of action and easy to titrate because of shorter half-life. So it is used as an adjunct therapy for refractory cases. So barbiturate are also GABA-enhancing drugs that work synergistically with benzodiazepine. They can be used orally or IV. Barbiturate have a narrow therapeutic range, and they have a long half-life period. So they are very hard to titrate and not use frequently. For the prevention, the best way to prevent alcohol withdrawal syndrome is to avoid regular heavy drinking. If you are already dependent on alcohol, you need to seek a proper medical care and counseling. The United States Preventive Services Task Force recommends screening patients for drinking problem through a careful history and a standardized screening questionnaire. During elective surgery, it should be postponed until the dependent has not hold alcohol for 7 to 10 days. For monitoring, patients with moderate to severe alcohol withdrawal symptom need close monitoring in ICU setting. We need to continue assess the vital signs, pulse oximetry, fluid and electrolyte status, neurological functions. And for prognosis, alcohol withdrawal is a common, but delirium tremens is only occurring in 5% of people, but it is very dangerous, can kill 1 out of every 20 people. After withdrawal is complete, it is essential like a person should not begin drinking again. On an average, an alcoholic who does not stop drinking can expect to decrease his or her life expectancy by at least 15 years. Thank you.